Okay, sige, last meeting, we started with our discussions about diuretic agents. A little review before we'll continue. When you say diuretic, our goal is to increase the urine output. And most of our diuretic agents are also natriuretic, which means we also increase the excretion of our sodium ion. Now, another thing that you need to know about diuretic agents are the parts where they act on the nephrons. So we are done with our loop diuretics. From the name itself, loop, their action is on this part, thick ascending limb of the loop of Henle. Okay, thick. Okay, if you compare the two parts here of the loop, this part here that is ascending is thicker, and this is where loop diuretics inhibit sodium and chloride reabsorption. Now, since this part reabsorbs a lot of sodium and water, then if we're going to prevent it or inhibit it, then that is the reason why loop diuretics are also called highest ceiling diuretic or our most powerful diuretic so far. Since you're going to give it to our patient, this will really drastically, or there is marked increase in the urine volume. Okay? And we are also done with our CAIs, our carbonic anhydrase inhibitor, which acts on the proximal convoluted tubules in this part. Actually, proximal convoluted tubule and a little part on the descending limb of the loop of Henle. Okay? However, nowadays, CAIs or the carbonic anhydrase inhibitors are mostly used for glaucoma and for mountain sickness disease, since it has a limited or self-limiting diuretic activity. Okay? Compared to the loop diuretics. And then here on the distal convoluted tubules, we have the thiazide diuretics. Okay, thiazide diuretics inhibit sodium chloride reabsorption in this part. And lastly, we have here on the last part, the collecting duct, which is connected to our urinary bladder. This is where naman our potassium-sparing diuretics take effect. They inhibit sodium and water reabsorption here. Okay? So again, that's the most important things that you need to know. So again, we started with carbonic anhydrase inhibitors. From the name itself, ayun na yung mechanism of action. They increase urine volume by inhibiting the carbonic anhydrase enzyme, and leading to the excretion of sodium as well as bicarbonate ion. However, since we are going to excrete the bicarbonate ion, then the patient may experience metabolic acidosis. Okay? And then we have the loop diuretics, our prototype drugs. We have the furosemide and the ethacrynic acid. However, we don't really use now the ethacrynic acid since this one is more toxic compared to the sulfonamide derivatives. Okay? So do not forget it's on the thick ascending limb of the loop of Henle. That is where they take their action. Okay? These are the clinical applications of our loop diuretics. We use them for hypertension and for several edematous conditions. Okay? And then the toxicity, do not forget that most of our diuretic agents are sulfonamide derivatives. Therefore, it is common that they may cause allergic reactions, skin reactions class. And then we ended here with the thiazide diuretics. Their action is on the distal convoluted tubule. Our prototype drug, our first drug discovered as thiazide diuretic is hydrochlorothiazides. And they are derived also from sulfonamide. Actually, thiazide diuretics are discovered due to the attempt na gumawa ng other drug coming from KAIS also, carbonic anhydrase inhibitor. Since the carbonic anhydrase inhibitor has self-limiting diuretic activity, they actually attempted to make another one, but they patterned the structure to KAIS. That is why both KAIS and thiazide diuretics are still sulfonamide derivatives. So we have here the following thiazide diuretics. Again, the most common one in the market is the hydrochlorothiazide. We have a single drug for this, and at the same time, we have a lot of combination drugs involving the HCTZ. Okay? Ulit-ulitin ko talaga, our thiazide diuretics inhibit sodium chloride reabsorption in the distal convoluted tubule. Okay? However, what's their difference with that of the loop diuretics? Since there is a limited or minimal amount of sodium chloride reabsorbed in the distal convoluted tubule, it is not really comparable to that of the urine output caused by the loop diuretics. So this is just modest increase in the urine volume excretion or increase. There is still some potassium wasting though, and there will be hypokalemic metabolic alkalosis that is due to the increase in the excretion of potassium. However, this is another difference of the thiazide and the loop diuretics. The loop diuretics increase calcium excretion. Okay, so in the urine, there will be more calcium excreted. However, for thiazide diuretics, there is an activity in the distal convoluted tubule that inhibits calcium excretion in the urine. So calcium is reabsorbed in the blood. Okay? Now, what are the clinical applications? Syempre, this is used for hypertension, for other cardiovascular diseases like heart failure, and at the same time, nephrolithiasis, or that's the kidney stones. Okay? That's the kidney stones. Ginagamit siya to excrete also some kidney stones, and nephrogenic diabetes insipidus. When you say diabetes insipidus class, this person has problem with sensitivity with the antidiuretic hormone. Okay, let me wait. When you say NDI, we have a problem on the sensitivity on the antidiuretic hormone. By the way, antidiuretic hormone is commonly called the vasopressin. Okay? Antidiuretic hormone. From the name itself, that is how our body regulates urination. We also release this hormone for us to not all the time release or excrete water from our body. Ang hirap din kung kada inom ihi, so madedehydrate din tayo niyan. Kung wala nang natira, lang tayong urinate, wala nang matitirang water in our body. So again, that's how we regulate urination. So the ADH, the antidiuretic hormone, is produced in our brain and take its effect on the kidneys, okay? Para ma-regulate yung urination. However, for people with nephrogenic diabetes insipidus, they have enough antidiuretic hormones but their kidneys are insensitive to it. Therefore, since their kidneys are insensitive, they will have frequent urination. And that will lead to, syempre, dehydration. Okay? So, insipidus means lasaw or labnaw. Lasaw ilahang ihi. Kasi nga, they are frequently urinating, and there will be times na yung iihi nila parang tubig na lang talaga. You know that our urine is yellowish in color. However, since again they frequently urinate, their urine will be more of like water itself. That is called again nephrogenic diabetes insipidus. This has nothing to do with our blood sugar. This is very different to diabetes mellitus. Mellitus class means viscous. And viscous because there is increased sugar in our blood. So that becomes viscous, and at the same time, if glucose is or sugar is found in our urine, that makes our urine viscous also. Mellitus. Sabi ko na. The opposite of insipidus is mellitus. Pero again, this condition here does not involve the blood sugar of the person. It's on the antidiuretic hormone. Okay? Now, remember class that diabetes insipidus involves frequent urination. However, the irony here is that we give them also the thiazide diuretics. Remember, the thiazide diuretics increase urine volume. And here comes the diabetes insipidus, that the patient experiences frequent urination. This is the irony here. They can't really, if we are going to read books, they can't really explain what is happening to the person with NDI. But fortunately, and actually, hindi talaga ma-explain, pag nagbibigay ng thiazide diuretics, napipigil nila yung urination. That's the paradox, that's the irony there. So again, the mechanism of action is not yet clearly known until now. Okay? Now for the toxicity, please remember the mnemonics hypergluc. Ito yung toxicity ng ating thiazide diuretics. Hypergluc. Hyper G for glycemia. Long exposure to thiazide diuretics can affect the pancreas in releasing insulin and at the same time regulation of the blood sugar. Therefore, the patient will experience hyperglycemia. That is also true for the lipids. Thiazide diuretics can also increase cholesterol deposition in the body, thus the hyperlipidemia. Now, we also have here hyperuricemia, that is due to the excretion of a lot of water. Okay? Kasi water class helps us in diluting the uric acid formed in our body. That is why if we are going to excrete a lot of water in the case of the use of diuretics, then we are also expecting that there is really an increase of the uric acid. Okay, so you observe people taking diuretics for a long time class. Tingnan nyo yung reseta nila, nadadagdagan talaga yan ng drug for uric acid. So yan talaga yung problema if we are going to excrete a lot of water from our body. And the C there is hypercalcemia. Remember, Unlike the loop diuretics, our thiazide diuretics inhibit the excretion of calcium. So calcium stays in our body and that may lead to hypercalcemia. Okay, increased calcium in our blood. And then, since thiazide diuretics are also sulfonamide derivatives, then we also expect here allergic reactions. Aside from the hypokalemic metabolic alkalosis. Again, when we excrete sodium and urine using thiazide diuretics, potassium also is excreted leading to this condition. Due to the hypokalemia, the patient may experience metabolic alkalosis. The pH of the blood increases. Okay? Again, it is called hypokalemic metabolic alkalosis. Okay, question so far about our thiazide diuretics. Before we'll move on with our potassium sparing diuretics. Alin doon ang hindi naintindihan? Pagkalimot ha, thiazide diuretics act on the distal convoluted tubule. Okay, the questions, let's move on. We have potassium sparing diuretics. So from the name itself, potassium sparing. Most of our diuretics also involve the excretion of potassium. However, for this kind of diuretics, the goal here is to increase the sodium and water excretion, but let's keep the potassium in the body. So this prevents secretion of the potassium by antagonizing the effect of aldosterone. Take note where at the late distal convoluted tubule and at the same time the cortical collecting tubules, or we call them collecting duct. Okay? Most of the board exam questions actually involves potassium sparing diuretics acting on the collecting duct. That's the major location where they take their action, the collecting duct. But take note that these potassium diuretics, potassium sparing diuretics affect the activity of aldosterone. I think I mentioned aldosterone last time. When you say aldosterone, it's a mineralocorticoid produced by the adrenal medulla. Okay, it's an endocrine gland located above the kidneys. And the function of this aldosterone is to keep sodium and water in the body. Or to simplify that, ang effect niya, sodium and water retention in the body. Hindi natin ma-excrete if the aldosterone works. So this is mineralocorticoid produced by the adrenal medulla. Okay? So what are these potassium-sparing diuretics? We abbreviate it as SIT. Okay? Now, we have the most common one, the spironolactone, or the brand name, we have the aldactone. But we also have the eplerenone, amiloride, and triamterene. So be familiar with them. Since mahirap silang tandaan, they don't have anything in common in their names except for spironolactone and eplerenone. They end with "-one". Okay? Now again, mechanism of action. Actually, their mechanism of actions are divided into two. These two have the same mechanism of action, while these two also have the same mechanism of action. So please take note ha, we have two mechanisms of actions for our potassium sparing diuretics. Ito sila magkasama. Anyway, do not be confused since they have the same ending in their names. And ito silang dalawa naman magkapareho ng mechanism of action. So let's start with our spironolactone and eplerenone. Okay? Now, these two, spironolactone and eplerenone, are actually synthetic steroid. Again, they are synthetic steroid, spironolactone and eplerenone. Now, since they are synthetic steroid, their mechanism of action is inhibition of the activity of aldosterone in the mineralocorticoid receptors. Actually, spironolactone really targets the aldosterone, while eplerenone is more on the mineralocorticoid receptors themselves. Again, spironolactone inhibits or antagonizes aldosterone, while eplerenone is concentrated on the mineralocorticoid receptors directly. Okay? Now, they inhibit the actions of these mineralocorticoids, leading to the excretion of sodium and water. But, again, sodium and water only, they spare the potassium. So, potassium stays in the body. So, na-mention ko na kanina, there is reduced retention ng sodium ha. So, na-excrete natin si sodium. And at the same time, sparing the potassium. However, the antagonism activity of aldosterone in the heart and the blood vessels are poorly understood until now. What are the clinical applications of these two? We're talking about spironolactone and eplerenone only ha. They can be given to patients with aldosteronism from any cause. Remember when you say aldosteronism, there is increased aldosterone in the body. Maybe this may be in terms of the amount of aldosterone, or there is increased activity of aldosterone in the body. Therefore, we can give the two, spironolactone and eplerenone, since they inhibit aldosterone's activity. And hypokalemia due to other diuretics. I don't know if you're familiar, we have the brand name called Aldacide, which is a combination of furosemide, what's the, not furosemide, hydrochlorothiazide, and at the same time spironolactone. Pinagsasabay sila, and that is because we are increasing the urine volume, but since there is the presence of the spironolactone, i-keep yung potassium, is-spare yung potassium. Yeah, we have the Hyzar, I'm not really familiar with the brand names, but hydrochlorothiazide yung most of the time in combination with other antihypertensive agents. Okay? But pag nakita nyo si spironolactone or the other potassium-sparing diuretics in combination with other diuretic agents, the goal there is to still increase urine volume and sodium excretion, but sparing the diuretics, the potassium, so that the patient will not experience hypokalemia. And then, aside from that, we give this also for people with that experienced myocardial infarction, or in layman's term, we call that heart attack. Okay? Now, how about the toxicity? Since we are sparing the potassium stays in our body, then the patient may experience hyperkalemia. Okay? Especially if the patient is also taking potassium supplement. Okay? Taas na hinon ang amount or ang level ni potassium in the body. Again, causing hyperkalemia. And for spironolactone only, this drug can cause gynecomastia. What do you mean by gynecomastia? Hindi ko lang ma-remember, but I think na-mention ko na ito dati. Ay, hindi ako sure. Pero anyone who knows what gynecomastia is? Yeah, sa guys, sa mga lalaki, what happened to them? Okay, very good. Sa breast nila, there will be increased amount of breast gland tissues. Sa breast nila. So, if the male class, yung mga lalaki natin are going to take spironolactone, there is a high possibility na lalaki yung kanilang breast. Okay? Breast size. But supposedly not. Hindi kagaya sa mga girls na lumalaki talaga yung breast size, no? As we mature from being like a child and then mag-adolescent, lumalaki talaga. Sa mga lalaki na talaga yung breast size nila. However, the downside of this, kapag lumalaki yung breast size nila, most of the time, only one breast. So, hindi siya pantay. Okay? So, what is the cause of this gynecomastia? Since spironolactone class is a synthetic steroid, it will also affect the aldosterone, not aldosterone, the androgen, the androgen, the testosterone, and even the female na hormone, the progesterone level in the body. Remember, these sex hormones are also produced by the adrenal medulla. Again, our sex hormones, testosterones, progesterones, are produced by the adrenal medulla. And if you're going to give the patient spironolactone, which is a synthetic steroid, maapektuhan yung numbers niyan, especially the androgen for male that will be inhibited. Therefore, ayun na yung reason why they'll have increased breast size. Pero again, most of the time, isa lang. Okay? Questions? Is a board exam question. Pero do not forget it's the spironolactone only, not including the eplerenone. Kasi the eplerenone acts more on the mineralocorticoid receptors directly. Okay? Now, let's move on. Pwede siya sa mga gays. Yung tinitake nila, diba, is steroid para dako sa ilahang breast size. Actually, spironolactone, sabi ko nga kanina, is a synthetic steroid. So, magpadako jud siya og breast size nila. Pero again, isa lang. So, dahil man dili sila gusto ko dili pantay. And at the same time, hindi din siya natin ibibigay sa mga gustong magpalaki ng breast size kasi this is diuretic. So the patient may be at risk of dehydration, especially if wala naman siyang sakit, tapos magte-take siya nito, made-dehydrate talaga siya. Okay? So ibang steroid yung ina-administer to members of the LGBT who wants to have bigger breast size. Pero corticosteroids are not really safe drugs. If I remembered it correctly, the adverse effects or the toxicity effect of the corticosteroids are also abbreviated as corticosteroids. So lahat ng letter dyan sa corticosteroids na yan, represents a toxic effect. Actually, the I there is increased blood glucose level. Corticosteroids can really cause like diabetes for patients. So, do not do that. And that is very painful for them. Remember class, mga babae, no? Itong going to teens tayo, pag di ba pag, let me use the word, the layman's term, namukol, pag namukol na ta, di ba painful? They will experience that also. As their breast size increases, they will also feel pain. And then again, they will experience a lot of things pa. Kasi remember, corticosteroids. When we are going to discuss corticosteroids class, let's get to know the meaning of the corticosteroids na toxicity ng corticosteroids themselves. Okay? Let's move on. So the other two, for our potassium-sparing diuretics, we have the amiloride and triamterene. Ito talaga yung nag-i-inhibit ng sodium chloride reabsorption in the collecting duct or in the collecting tubule. So 'di ba, sabi ko kanina, our potassium-sparing diuretics act on the collecting duct. Sila yon, silang dalawa, amiloride and triamterene. So, they reduces water retention and sodium retention, which means these two are excreted, but they reduce potassium wasting. So, they are sparing potassium also, just like our spironolactone and eplerenone. And another good side of our triamterene and amiloride is they increase lithium clearance. So the lithium ion is not really good in the body. So if there is lithium poisoning, for us to excrete the lithium, we can give these drugs. Okay? Kasi again, they increase lithium clearance. Clinical applications of the two, triamterene and amiloride. We have hypokalemia from other diuretics. Therefore, this can also be given in combination with other diuretic agents. Our goal again is to prevent loss of potassium. And again, since this can cause increased renal lithium clearance, then in cases of lithium poisoning, we give the two. Reduces lithium-induced polyuria. Kasi too much lithium in the body can actually cause, when you say polyuria, what do you mean by that? There is frequent urination. Yeah, excessive urination. Yun yung gagawin ng lithium. Iihi ka ng iihi pag marami kang lithium in the body. So let's excrete the lithium and prevent polyuria. Okay? Now, toxicity of these two, hyperkalemic metabolic acidosis. Okay? Tataas yung potassium in the body, leading to the decrease in the blood pH. So this time, it's acidosis. Most of the time, class, the drug's toxicity are just extension of their effect. Okay? Kagaya ng anti-hypertensive drugs. Pag mag-isip ka ng not toxic effect niyan, extension lang yan ng kanyang effect. Meaning, tambal siya sa high blood. I'm using the layman's term ha. Tambal siya sa high blood. So, ang iyahang toxic effect ana, hypotension. Ito naman, potassium-sparing diuretic siya. So, ang toxicity will be hyperkalemia. So, most of the time, that's true for the drugs. Their toxicities are extensions of their effect talaga. Extension means this one is excessive. Excessive na pag nag-stay na ang potassium in the body, syempre, pag marami na masyado, mag-hyperkalemia ka na. Okay? Questions or clarifications about our potassium-sparing diuretics? Wala? Wala. So let's move on to our osmotic diuretics. Our prototype drug for our osmotic diuretic is the mannitol. Okay? I hope you have observed them in the hospital setting kasi doon talaga ito ginagamit. We seldom see this or we seldom dispense this sa community. Again, mannitol is used mostly in the hospital. Now, from the name itself, osmotic diuretic, syempre, ang activity nito, ang mechanism of action nito involves osmosis. So, what do you mean by osmosis? What do you mean by osmosis? Mannitol class is an osmotically active agent. Pero take note as I'm waiting for your answer of what osmosis is. The part ng nephron where the osmotic diuretics take place is the proximal convoluted tubule and at the same time the descending limb of the loop of Henle. So proximal convoluted tubule connected to the first part of the loop of Henle, that's the descending limb pababa. That is where the osmotic diuretics act. Movement of water, diffusion of water. Movement of water from higher to lower concentration. Baliktad, lower to higher. Solute concentration. Movement or diffusion of solvent molecules. Okay, very good. When you say osmosis class, there is movement of solvent. Sorry, I don't have my pen. Ano ang nag-move sa osmosis? It's the solvent. And most likely, our solvent in the body is water. Okay? So, ano yung movement niya? It's actually from higher, baliktad. Sorry. Delete. From lower. This is from lower to higher solute concentration. Okay? Pag mas maraming solute, mag-move ang water doon. Bakit? Kasi the goal of osmosis is dilution. Okay? Again, the goal of osmosis. Why osmosis happens? Kasi the goal is to dilute. Therefore, you have one compartment in the body here. It has a lower solute concentration. Then you have one compartment here na marami siyang solute. Ang mangyayari class, water will go there. Kasi, again, this should be diluted. Madidilute siya. Kasi marami siyang solute. Therefore, pag binigay natin si osmotic diuretics, what will happen to the body? Since mannitol is osmotically active, kung nasaan siya, water will follow. That makes it a diuretic. Kung nandoon siya class, since mannitol is filtered by the glomerulus and going to the nephron, water will follow. So our water from the blood and from other tissues will follow, leading to water diuresis. Water ang mag-move for our mannitol or osmotic diuretics. Again, the mechanism of action involved osmosis, osmotic effect, and that will be on the proximal convoluted tubule and the descending limb of the loop of Henle. Okay, so what are the effects? If we are going to give mannitol to our patient, syempre, there is marked increase in the urine flow. And at the same time, reduced brain volume, especially if there is water in our brain, too much water sa brain natin, mare-reduce talaga ang volume ng brain natin kasi nga there will be osmosis. So it's not just about water in our blood, but also water in our tissues. This is also true for the intraocular pressure. Water from our eyes will also move following our osmotically active agent, example, the mannitol. Therefore, there will be also decrease in the IOP. And then initially, there is hyponatremia and then hypernatremia. That's the effect of the mannitol. Since ang talaga activity niya is movement of water, water lang yung magmo-move class. So, maiiwan si sodium. So, initially, magkakaroon ng hyponatremia due to the initial movement. However, since water lang talaga yung ma-excrete, maiiwan si sodium. So, leading to increased sodium in the body. So, kaya kung nakikita nyo dyan, there is initial hyponatremia and then there is hypernatremia. So, what are the clinical applications of our mannitol or our osmotic diuretics? We have here renal failure due to increased solute load. Kapag marami masyadong solute, kung ano mang solute yan, sodium man yan or other ions, and then pag marami na siya masyado sa kidneys, that may lead to kidney failure. So we can give mannitol class to dilute it. Okay, so that water will move to the kidneys and then diluting the solute load in the kidneys. Yeah, edematous conditions also. We use class mannitol to move the water from the edematous tissues. And then we can also use this mannitol and other osmotic diuretics for people experiencing increased intracranial pressure. So I don't know if you have observed that during your hospital internship, but most of the people who are given with mannitol in the hospital are those na may, example, brain tumor. Kasi pag may brain tumor, mataas ang pressure sa brain mismo due to the presence of the tumor. So the movement of water is affected. So to decrease that, kukunin yung water through osmosis via the mannitol. Or kung walang brain tumor, those persons who experienced road accidents, tapos merong head injury. Okay? Pag may head injury kasi, tumataas din ang pressure sa brain, leading to accumulation of water sa ulo. Okay? So, we are going to drain that water using the mannitol or the osmotic diuretic. And syempre, since this can decrease intraocular pressure, the osmotic diuretics are also given to persons with glaucoma. Okay? How about the toxicity? Nausea and vomiting, headache. These are common adverse or toxic effect of drugs. So ito talaga yung sinasabi ko sa mga estudyante. Pag nagtanong ako sa inyo ng toxicity or adverse effects ng drug, do not give me nausea and vomiting and do not give me headache. Kasi these are common for most of our drugs. So ibigay niyo sa akin yung unique for that certain drug. Okay? Now, toxicity, extracellular volume expansion. Anong ibig sabihin yan? Extracellular means sa labas ng cell. Kasi nga, there will be osmosis, there is movement of water. Yung water sa loob ng cell ay lalabas. Okay? So again, lalabas. So kaya there is extracellular volume expansion. There can be dehydration since we are excreting water. There will be hyperkalemia and hypernatremia because again, only water is excreted. The solute is left in the body. Pero there is initial hyponatremia class. This is the initial reaction before mag-experience ang patient ng hypernatremia. Okay? Questions? This is actually the end of our diuretic na topic. Ang next na topic will be about antidiuretic hormone. Wala. Wait lang, hanap po tayo. Give me 5 minutes. Let's take a break. Yeah. Sige. Sige, let us continue. Let's talk about antidiuretic hormone agonists. Okay? Agonist ha, para hindi makaihi. Our vasopressin class, that's the name of our antidiuretic hormone. Itong desmopressin, it's the synthetic one. So please take note of that. Again, vasopressin is our antidiuretic hormone, while the desmopressin is the synthetic one. Now, where do we use them? We use them for people who are experiencing central diabetes insipidus. Ano kaibahan ito ng minention natin kanina? Yung sa thiazide diuretic that was nephrogenic diabetes insipidus. Ano nga ito? The patient has enough antidiuretic hormone. The problem is the kidneys are insensitive. However, if you say central, this is another one. Central diabetes insipidus. The difference is, for people with central diabetes insipidus, the problem is they don't have enough antidiuretic hormone, which means their brain is not really producing ADH. Hindi enough yung pinoproduce na ADH. Kaya siya central. Kasi the problem is on the brain itself. The part of the brain that produces the ADH. Yung nephrogenic, ang problem is ang kidneys. Okay? So, since the problem for central diabetes is insipidus is there is no enough ADH, then we give them ADH. And that is the vasopressin. Or if vasopressin is not available in the market, then we can give the desmopressin. I hope that is clear, class. Klaro yan. And then, syempre kung may agonist tayo of the antidiuretic hormone, meron din tayong antagonists. Okay, antidiuretic hormone antagonist. Our goal here is to antagonize the activity of the antidiuretic hormone to help the patient urinate. Okay? Para makaihi. Kasi nga antidiuretic hormone, hindi i-regulate yung pag-ihi. Ito, i-antagonize natin para makaihi yung ating patient. So what are the conditions na binibigyan ng antidiuretic hormone antagonists? We have the CHF. CHF means congestive heart failure. And the SIAD. We call that SIAD. SIAD means syndrome of inappropriate ADH secretion. For the CHF, congestive heart failure, since the problem is on the heart, kailangan kasing i-release yung excessive water because excessive water, especially in the blood, will not really help the heart. May problema na nga siya sa heart, nahihirapan na magtrabaho ang heart niya. Tapos dadagdagan mo pa yung volume ng blood na ipapump niya. Hindi yun makakatulong for persons with CHF. So that is the reason why we can antagonize the antidiuretic hormone for the patient to release the excessive fluid in the body. Now, for the SIAD naman, that again is syndrome of inappropriate ADH secretion. Kabaliktaran ito, class, ng central diabetes insipidus. Diba? Si central diabetes insipidus, hindi nagre-release ng ADH yung brain. Ito naman, merong inappropriate na ADH secretion. Maraming pinoproduce na antidiuretic hormone. So, i-antagonize din natin. Yun yung gamit ng mga antidiuretic hormone antagonists. So, what are the examples of drugs that antagonize the antidiuretic hormone? We have the first one here, the conivaptan. These are not common drugs, so paano na lang, double the effort again kasi hindi common the mga drugs. So what is the mechanism of action of conivaptan? This is an antagonist at the V1A and V2 ADH receptors. The names of the receptors of the ADH are the V1A and the V2. I-antagonize niya yung receptor para hindi makapag-bind yung antidiuretic hormone. Diba? Maraming ang ADH, yung sa case ng SIAD, maraming ADH yung patient. So, pigilan natin yung pag-bind ng hormone na yan doon sa receptor niya para hindi siya makatake ng action. So, that's what conivaptan does. Mauuna siya doon sa receptor, blocking the activity of the antidiuretic hormone. So, what is the effect of blocking these receptors? There will be reduction in the water reabsorption. So, antagonize natin si antidiuretic hormone, ang labas, makakaihi ang patient. Hindi na reabsorb ang water. Instead, ma-excrete siya. However, there will be increase in the plasma sodium concentration. Since we are just dealing with the ADH, then we are dealing with water. So what moves here is water. Maiiwan si sodium, thus the patient may experience hypernatremia. Okay? So what is the clinical application of conivaptan? We can give this to patient with experiencing hyponatremia. Kulang yung sodium sa body. So pag binigay natin si conivaptan, nag-move si water, na-release natin si water, pero naiwan si sodium. Remember, there is increase in plasma sodium concentration. Naiwan si sodium, therefore, treating the hyponatremia of the patient. And, syempre, SIAD. Syndrome of inappropriate antidiuretic hormone secretion. Okay? Inhibit natin yung activity niya. How about the toxicities of our conivaptan? This one class is given intravenously. So there might be infusion site reaction. So kung saan in-infuse, magkakaroon siguro, pwedeng may possibility na magkakaroon ng allergic reactions, for example, or problems on the injection site. And then another one is nephrogenic diabetes insipidus. That becomes a toxicity now of the SIAD, no? Ay, of the conivaptan, no? Kasi nga ininhibit natin yung receptor. Si antidiuretic hormone hindi na makakabind sa receptor niya. And these are found in the kidneys. Therefore, the patient may experience insensitivity to the ADH sa kidneys mismo. Kaya naging toxicity niya dyan si nephrogenic diabetes and insipidus. And there might be a possibility of renal failure, especially if too much exposure, a very large dose of the drug, pwedeng mag-renal failure ang patient. Kasi this one is not really normal. Ini-inhibit natin yung activity ng antidiuretic hormone. So, ihi lang ng ihi, trabaho lang ng trabaho yung kidneys. Again, that may lead to renal failure. And then lastly, we have the DEMECLOCYCLINE. Brand name niya itong declomycin. So, just like the conivaptan, this is also an antagonist of the antidiuretic hormone in the receptors, which are actually found in the kidneys. Okay? Now, another board exam question. The DEMECLOCYCLINE class is originally used as an antibacterial. This is actually an antibiotic, antibacterial antibiotic. Kasi this is a kapamilya of the tetracyclines. I don't know if you are familiar with the tetracycline, but tetracyclines class are antibiotics. And kapamilya niya itong DEMECLOCYCLINE. Pero aside from being an antibacterial, this can also antagonize the activity of the antidiuretic hormone, thus nasali siya dito. Kasi minsan tinatanong ito sa review or sa board exam, ano daw yung antibacterial agent na pwedeng gamitin for Example, syndrome of inappropriate antidiuretic hormone secretion. That's again the DEMECLOCYCLINE. Okay, that ends our chapter 18. Do you have questions or clarifications so far? Wala. Kasi nabot ta sa atong diuretics, ha? Kasunod, mag-duty mo sa community. I hope you are now familiar with the different diuretics that we have. Aside from their names, you have to know where on the nephron they take their action. Wala, sure na. Hilom lagi kayo mo.